we hope that you're here for our Lung Cancer Management in North Carolina updates for 2022 with Shetal A. Patel, MD, PhD. And I do want to tell you that Dr. Patel completed her degrees at the University of Pennsylvania, studying cancer biology in the laboratory. After completing her internal medicine residency at Brigham and Women's Hospital, she returned to the University of Pennsylvania to complete a fellowship training in medical oncology. Her clinical focus at UNC is treating patients with thoracic and head neck malignancies. Her research interests include developing translational studies and clinical trials to improve treatment options for patients, with a particular focus on novel immunotherapies, genomic profiling, and targeted therapies. Dr. Patel, welcome.
Thank you so much for having me.
Absolutely. We are thrilled to have you. Glad to have you back. You're a star presenter here at UNC Lineberger Cancer Network, and we're really glad to have you back. What's something we should know about you outside of your professional bio?
So my goal for this spring is to have a garden with my kids. So that'll be my new hobby for the fall.
Oh my gosh, that sounds great. That sounds great. Have you got anything started yet?
Just flowers at this point, but those are a hit, so we gotta expand.
Good for you, and great for all those pollinators too. So that is outstanding. Well, let's go ahead and I mentioned poll everywhere. I'm going to get, this is not the actual poll. This is a preview slide. So two major types of lung cancer are non-small cell lung cancer and small cell lung cancer. True or false? Again, everything anonymous, no risk in answering these. We'll get back to the real poll in just a minute. And while you're thinking about that, I'll say this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Greensboro Area Health Education Center is approved as a provider of nursing continuing professional development by the North Carolina Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Shetal A. Patel, MD, PhD, has no relevant financial relationships with commercial interests as defined by the ACCME. And here's that poll. We're already strongly trending on that true. We'll give that a few more seconds for anyone who hasn't had a chance to respond. Dr. Patel, how is our audience doing so far?
Great. Perfect.
Okay. Good. All right. Well, we're off to a great start. I'll turn it over to you. Lung Cancer Management in North Carolina, updates for 2022.
Great. Well, thank you for that kind introduction, and I look forward, sorry, losing my voice at the beginning here, to providing some updates on new therapy options for patients with lung cancer. You can go to the next slide, please. No relevant disclosures. You can go to the next slide. So our learning objectives for today are to describe the importance of comprehensive biomarker testing and how it can inform treatment decisions for patients with non-small cell lung cancer, and particularly in the context of using this information to recognize biomarkers for some of newly approved therapies that we'll be talking about today. And then I'll focus on some new roles for immune checkpoint blockade in patients with early stage lung cancer. Next slide. So just a little bit more detail about our outlined topics for today. First, we'll be going over approaches for molecular testing in lung cancer, and then going over the data for two new targeted therapy approvals, those targeting KRAS G12C mutations, as well as EGFR exon 20 insertion mutations, and then finally ending with the data for immune checkpoint blockade in patients with resectable disease. You can go to the next slide. So starting off our discussion with a patient case, BT is a 70-year-old female, former 30-pack-year smoker who presents to their doctor with left neck swelling for several weeks and has some imaging done that shows supraclavicular lymphadenopathy and is found to have a lung mass, as well as additional lymph nodes and bilateral lung nodules. So they're referred for a biopsy as one of the initial steps in their diagnosis and have a core biopsy performed of the supraclavicular mass. And the pathology on that shows a non-small cell carcinoma that's consistent with the lung adenocarcinoma with this immunohistochemical profile described here. Next slide. So we know that from a diagnostic perspective, lung cancer can be subdivided into several groups. One of the major classifications, as we talked about before, is non-small cell cancers versus small cell cancers. And then non-small cell cancers are further subdivided with adenocarcinomas, which are often positive for markers such as TTF1 and napsin and CK7, as well as squamous cancers, which have a different marker pattern, including P40 and P63. There are several other less common histologies in non-small cell cancers, including large cell neuroendocrine cancers or sarcomatoid cancers. And then small cell lung cancer is a different bucket of diseases that's treated differently. And these have neuroendocrine markers, including CD56, chromogranin, and synaptophysin. While in the diagnostic algorithm, this initial pathologic classification is important, we've learned over the years that lung cancer is actually really much more heterogeneous at the genomic or molecular level. Next slide. Particularly for non-squamous or lung adenocarcinomas, we've learned through genetic profiling that there are a number of different genetic alterations in genes that can be targeted with FDA-approved agents. So this pie chart summarizes those, including starting with the prototypical mutation, which was in EGFR sensitizing mutations, which there are a number of different generations of targeted kinase inhibitors that are available for, and to newer approvals such as drugs that target MET exon 14 mutations, as well as RET fusions. And today I'll be focusing on some of the newest approvals that are focused on targeted therapies in non-small cell lung cancer, including agents that target mutations in KRAS, which has long been considered one of the undruggable genetic changes in lung cancer, as well as this class of other EGFR mutations that don't fall into the bucket of EGFR sensitizing mutations. Next slide. So how do we identify these genomic changes since they're so important in therapy selection? Well, there are a number of different approaches. One is to use tissue-based sequencing, which can be done on a biopsy specimen. And this can be done through next-generation sequencing, which we'll go into more detail about, or more focused approaches that look at just individual genes, such as polymerase chain reaction or PCR. Then for fusion events, fluorescence in situ hybridization or FISH can be useful. And protein-based methods such as immunohistochemistry are also used for other biomarker selection. In addition to tissue-based testing, we also now commonly use blood-based or liquid biopsy approaches to help fully characterize the genetic changes that are present in lung cancer, given the importance for therapy selection. Next slide. So what is next-generation sequencing and how does it differ from older methods of genetic profiling? So in contrast to single gene sequencing, next-generation sequencing has the ability, through the high throughput approaches, to really look at a large number of genes concurrently. And since we have a number of different genetic changes that can now be targeted with FDA-approved drugs, this is particularly important. So the advantage of next-generation sequencing over single hotspot panels is that it can be much more comprehensive, and with a smaller amount of material, you can get information on genetic changes across a number of different targets. But there are certain limitations to this approach. Because of the specialized nature of this testing, it's often done in core laboratories, not at individual institutions, and that can impact the turnaround time and the interpretation of the results that we get from these assays. Next slide. So in addition to next-generation sequencing that's done on tissue-based specimens, that same sequencing approach can also be done on blood-based specimens. So blood-based testing is a non-invasive approach where you don't have to have a biopsy to get this genomic information. And it relies on the fact that tumors will shed some of their DNA into the bloodstream, referred to as circulating tumor DNA, which can then be isolated and tested for genetic changes that are present in the tumor. In addition to genomic material from the tumor, a number of other blood-based assays are being investigated. And the EGFR test, which was used as a companion diagnostic for EGFR tyrosine kinase inhibitors, was actually one of the first plasma-based companion diagnostics that was approved. In addition to being able to look at single genes like that EGFR test, there are now next generation or broader sequencing panels that also can be done on blood or plasma specimens that can allow for more comprehensive profiling of all the genetic changes that we now have targeted therapies for. So these approaches can be helpful when there's limited tissue available from a biopsy, or when turnaround time is an issue and we don't have the time to wait for the 2 weeks that it may take to get a tissue-based biopsy results genetic sequencing back. Next slide. So because of the more common use of blood-based testing, the International Association for the Study of Lung Cancer has put out some recommendations on the diagnostic algorithm to get comprehensive testing on newly diagnosed advanced or metastatic non-small cell lung cancer patients. So in their algorithm, they recommend that in patients that have a tissue sample that appears sufficient for tumor genotyping, the tissue sample can be sent as sort of the gold standard for complete genomic profiling. But in those patients in which there is a concern for the amount of material on that tissue specimen, whether it may be sufficient for complete sequencing, or if there is no tumor material available, then plasma-based testing or blood-based testing could be used as a first approach to help identify these mutations and get comprehensive profiling for patients. And to really ensure that all potential therapeutic options are investigated in patients that don't have targetable drivers identified by a plasma-based approach, it is still recommended to try to obtain a rebiopsy for tumor or tissue-based testing. Next slide. So returning to our patient example, they have a biopsy specimen that is submitted for next-generation sequencing given the identification of a lung adenocarcinoma, but there's insufficient material. So the patient then has a liquid biopsy performed, which identifies a KRAS G12C mutation in circulating tumor DNA. They also have immunohistochemistry for a marker for immunotherapy, PD-L1, which we'll talk a little bit more about, which shows a tumor proportion score of 20%. So the patient is initially started on treatment with a combination of chemotherapy and immune therapy, but unfortunately after some time their disease progresses. What other therapeutic choices does this patient have? Is KRAS something that can now be targeted? Well, fortunately the answer to that question is yes, and we'll go over some of the data for this. Next slide. So KRAS mutations, which account for a large fraction of the mutations that we see in lung adenocarcinomas, were long considered undruggable. And there have been a number of trials that have used various agents to try to address KRAS in lung cancer. Fortunately, through recent drug discovery efforts, there's been a number of small molecule inhibitors that have been identified that specifically bind to the G12C variant in KRAS, which is found in about 13% of lung adenocarcinomas. And you can see from the structure here that there are a number of different agents, and they specifically bind to this switch II pocket that's present in G12C mutated KRAS. These are irreversible inhibitors that bind and keep KRAS in the inactive GDB-bound state. And I'll go through some of the data that has been coming out on these agents in lung cancer over the next couple of slides. Next slide, please. So first, going through the CodeBreak 100 study, which evaluated sotorasib, or AMG 510. This was a phase 2 study that took patients with locally advanced or metastatic non-small cell lung cancer who had a G12C mutation that was identified on tumor specimens by central testing. These patients had all been treated previously with other prior standard therapies, including platinum doublet chemotherapy or immune therapy, and stable brain metastases were allowed. Patients were treated with sotorasib at the 960 milligram once daily dose until disease progression, with scans every 6 weeks. The primary endpoint of the study was overall response, and we'll go through the data in the next slide. So in the baseline characteristics, just to summarize for these patients, median age in the 60s, performance status of 0 or 1. In contrast to other targeted therapies, KRAS mutations are often seen in patients that do have a smoking history, so you can see the majority of patients were either current or former smokers, and that they had had 1 to 3 lines of prior therapy. In addition, most patients had previously been treated with both platinum doublet chemotherapy as well as immunotherapy. Next slide. So now going into the tumor response data. So in the 124 patients that were included in this phase 2 study, the confirmed objective response rate was 37%, with a disease control rate of a little over 80%. The median duration of response was around 11 months, and as we'll look at in the next slide, the median progression-free survival was a little over 6 months. The median time to response was also just a little over 1 month. Next slide. So this is the Kaplan-Meier curve for progression-free survival for Shetal in this phase 2 study, showing a median progression-free survival of 6.8 months, as we discussed. Next slide. So the authors then looked at specific molecularly subdefined groups in the study. And this is because in other studies of chemotherapy as well as immune therapy, we've seen that when certain other alterations are present with KRAS, this can impact the efficacy of chemotherapy and immune therapy. So two mutations that have been of particular interest are STK11 and KEAP1, as both have been associated with decreased response to standard therapies in KRAS mutated patients. So the authors looked at various subgroups of either STK11 or KEAP1 mutated patients in this cohort, and they saw, encouragingly, that in the subgroup of patients that had both KRAS as well as STK11 mutations, there seemed to be an encouraging response rate of about 50%, with a progression-free survival of 11 months and overall survival of 15 months. Now, this has the caveats of being a smaller subgroup and an exploratory analysis, but this is something that is being explored in larger groups of patients, given the poor outcomes that have been seen with KRAS and STK11 co-mutated patients with other standard therapies. So more to come. Now going over some of the safety data for sotorasib, you can see here that overall their treatment emergent adverse events we're seeing in about 20% of patients being grade 3 or more. Overall, the side effect profile was less severe and more intolerable. Most common side effects seen were diarrhea, nausea, as well as LFT abnormalities. There were no fatal treatment emergent adverse events, and only about 20% of patients required dose modifications. And a smaller percentage of patients had to discontinue therapy related to adverse events. Most of those were related to liver injury or LFT abnormalities, and uncommonly there were 2 patients that also developed pneumonitis that led to treatment discontinuation. So overall, a good safety profile, and this collective data has led to the approval of sotorasib as an agent that can be used to target KRAS in previously treated patients. Next slide. So as we had seen in previous studies and focusing more on our specific patient, they were found to have the KRAS mutation present in the blood or in the circulating tumor DNA. Are these results in the circulating tumor DNA actionable for this patient? By finding it in the blood, can we say that this is something that can be targeted with this new agent? Well, overall, we've seen from other studies that have looked at the concordance of blood and tissue-based testing that there does seem to be a high concordance rate for these, particularly for driver alterations such as KRAS, EGFR, and ALK. The sensitivity can be variable. Some patients may not be shedding significant amount of tumor into the DNA into the blood, in which case we may not detect these alterations in the blood, and that's where complementary tissue-based testing can be useful. But overall, circulating tumor DNA alterations have been found to be actionable in other cases, and patients can have responses when these are found in the blood for driver mutations. And they can also be particularly helpful for following some of these alterations in a longitudinal fashion to identify potential resistance mechanisms. And as with all of these genomic testing results, they do have some caveats that are important to think about as you're interpreting results. For blood-based testing, the challenge is always knowing whether some of the alterations that you're identifying are all derived from the tumor or whether they may be from other sources. And so subclonal mutations may not be from the tumor themselves, but from other processes such as clonal hematopoiesis. And then identifying fusions has been challenging with circulating tumor DNA results. Focusing back on data for this patient, next slide. The CodeBreak study did evaluate whether the identification of KRAS mutations in the blood could also correlate with response. So in this phase 2 study, they were able to collect blood from a little over 100 patients, and they did circulating tumor DNA analysis using a platform called Guardant 360. And you can see here that about 77 of the 107 patients that had this testing available were positive for the KRAS mutation by Guardant 360 testing, and that the response rate in patients that were found to be positive by Guardant testing was similar to the response rate in the overall patient population, so a little over 30%, with similar disease control of about 78%. And so overall, as we've seen with other targetable alterations, finding these in the blood can be something that can be used for selecting patients for these targeted agents. Next slide. Now, in addition to sotorasib, which is the first approved agent for KRAS G12C inhibition, there are a number of other KRAS G12C drugs that are currently in the pipeline. So I'll provide a little bit of data on adagrasib, which is one of the furthest along in terms of clinical studies. So this has gone through phase 1 testing, is now being evaluated in larger phase 2 cohorts. This is a waterfall plot summarizing the data for adagrasib in non-small cell lung cancer, both from the phase 1, phase 1b, and phase 2 patient population. And as you can see here, encouragingly, similar to sotorasib, a high disease control rate with 96% of patients exhibiting disease control, and the response rate in this cohort of lung cancer patients of about 45%. So I think we'll see multiple KRAS G12C drugs being approved over the next few years, and as well as potential new roles for these drugs in earlier lines of therapy. Next slide. So that summarizes some of the data for KRAS G12C inhibition. Next, I wanted to turn to another group of mutations that we see in patients with non-squamous or lung adenocarcinoma, which is EGFR mutations that are not sensitizing to the currently approved EGFR tyrosine kinase inhibitor, so other mutations. Next slide. And what this highlights is that mutations in these genes are not all the same. So the canonical sensitizing mutations for EGFR are found as exon 19 deletion mutations or a point mutation at L858R that are sensitive to the first 2 third-generation kinase inhibitors that we have, such as erlotinib or osimertinib. But what you can see here is that as we've done more sequencing of lung cancers, we've actually found a number of other EGFR alterations which fall in other parts of the kinase domains. And these can be activating, but to date had not been sensitive to the earlier generation EGFR drugs that we have. So I'll be focusing on insertion mutations in exon 20 of EGFR, which have been an area of interest for development because they are not sensitive to the previously approved therapies. Next slide. So one agent that has been looked at in this patient population with EGFR exon 20 insertions is Amivantamab, which is a fully human EGFR and MET bispecific antibody that is thought to have a couple of different mechanisms of action, as you can see on the right here. This antibody can prevent ligand binding, both for EGFR as well as MET ligands, but then it's also thought to increase receptor degradation by internalization and may have some immune properties by stimulating antibody-dependent cellular toxicity. This agent has now been looked at in patients with exon 20 insertions, as well as a number of other biomarker populations, which we'll review in the next slide. So the Chrysalis study looked at amivantamab. It was a phase 1 study that had dose escalation as well as expansion in a number of different biomarker-selected cohorts. So I'll be summarizing the data in the group of patients that were treated that had exon 20 insertion mutations and have been previously treated with platinum chemotherapy. Collectively, including all the patients from the dose escalation and the dose expansion, they had an efficacy population of a little over 80 patients and evaluated as their primary endpoint objective response, clinical benefit rate, and duration of response, with secondary endpoints of PFS and OS. The next slide to summarize some of the data from this study. So this is the spider plot of patients with EGFR exon 20 mutations that were treated with amivantamab in this Chrysalis study and recently published in the Journal of Clinical Oncology. What you can see from the waterfall plots is really quite encouraging, the percentage of patients that had partial responses, and based off of the time frame on the bottom, those responses were often quite durable, so providing durable disease control. And there was also a fair group of patients that had durable stable disease as well. Go to the next slide. So summarizing some of the subgroup analysis from this study, the confirmed objective response rate for amivantamab was 40% with a clinical benefit rate of 74%. And when they looked at different patient subgroups, they saw that this objective response rate was pretty consistent across age, gender, as well as previous lines of therapy. And as we'll go through in some of the next slides, patients that had previous EGFR tyrosine kinase inhibitor therapy also seemed to respond as well. So in contrast to the more common EGFR exon 19 and L858R mutation, these exon 20 insertions actually include a quite heterogeneous group of specific genetic changes. So they look to see whether all those different exon 20 insertions were similarly responding to this agent. So this is a waterfall plot summarizing the data for that. In the study, they looked at this exon 20 insertion using the Guardant circulating tumor DNA testing platform, and they categorized them into various portions of the kinase domain, either the helical region or near or the far loops. What you can see overall looking at this plot is that there was good disease control and responses seen across these different domains of exon EGFR exon 20. So we're seeing activity for this agent across different mutation types. Next slide. And looking at the safety data for amivantamab, overall safety data in the top table, you can see that the rate of grade 3 or greater adverse events was about 35%, but relatively low fraction of patients that had to discontinue therapy due to an adverse event, about 10%. The most common adverse events were some typical of EGFR inhibition, including rash, paronychia, diarrhea. Some that are unique to this agent are that infusion-related reactions were seen in a substantial number of patients. These were often only with the first infusion and typically did not recur, so there are some specific dosing and pre-medications for this agent that are important to consider in clinical practice. Other adverse events that may be related to the MET inhibition portion of this drug included hypoalbuminemia and peripheral edema. But overall, given the rate of dose reductions and discontinuation needed, a safe treatment, and this has led to the approval of amivantamab as an agent that can be used in patients with previously treated non-small cell lung cancer with these EGFR exon 20 insertions. And there are a number of studies that are ongoing looking at this in combination with chemotherapy as well as the earlier lines of therapy for these patients. Next slide. Another agent that's been looked at in patients with these exon 20 insertions is mobocertinib, or TAK-788. This is an oral tyrosine kinase inhibitor that in preclinical studies had been shown to have activity in these specific EGFR exon 20 insertions. So it was evaluated in a phase 1 study initially for dose escalation and then moving into a number of different dose expansion cohorts in the phase 2 portion. Including patients that had the exon 20 insertion as well as HER2 insertions. And so I'll be focusing on the group of patients that received mobocertinib that had had previous platinum doublet chemotherapy, as well as a subgroup of patients that had been previously treated with a tyrosine kinase inhibitor. The primary endpoint of this study was objective response, disease control, PFS were some of the secondary endpoints. Next slide. So in the population of patients that were treated that had previously had chemotherapy, those was the PPP and the exclaimed cohorts of this study, you can see that the confirmed response rates were in the high 20s to 30% based on whether you look at it at the central confirmation or the investigator assessed confirmation, and that the duration of response was pretty significant, ranging into the 17-month range for the independent review confirmation. The median progression-free survival for this agent was a little over 7 months, and encouraging overall survival of over 24 months for this patient population. The next slide. Here's the plot showing the response rate in mobocertinib in different EGFR exon 20 insertion mutations. So as we had talked about before, this is a heterogeneous group of genetic changes, and what they saw was activity across different genetic changes at the specific insertion point from this plot here. Next slide. This subgroup analysis specifically focused on the group of patients that had previously been treated with an EGFR tyrosine kinase inhibitor, so a smaller cohort of 20 patients. As we talked about before, older EGFR kinase inhibitors did not have substantial activity in this patient population, but in this group of patients, mobocertinib did demonstrate objective responses in about 40% of patients, suggesting that even in patients that had previously been treated with these TKIs, this agent could have activity. Now, safety data for mobocertinib is also important to consider. This agent, similar to what we've seen with other EGFR targeting drugs, has side effects such as diarrhea, rash, paronychia. But some of the concerning areas here is that there was a pretty substantial number of patients in which these adverse events led to either dose reduction or dose discontinuation. You can see that about 25% of patients, either in these two cohorts, needed some kind of dose reduction to make these treatments more tolerable, and that there was about 10 to 17% of patients who actually had to discontinue therapy because of treatment-related adverse events. And diarrhea is one of the most prominent ones with this agent that can be sometimes difficult to manage. But collectively, this data has led to the approval of mobocertinib as another agent that can be used to target patients with EGFR exon 20 insertion mutations that have been previously treated with chemotherapy. And we can go to the next slide to talk about the question. So which of the following genomic alterations do not currently have an FDA-approved therapy for non-small cell lung cancer? Well, that's absolutely right. So KRAS G12D does not currently have an approved therapy. And that just highlights the fact that all mutations in these genes are not the same. So the drugs that we have currently to target KRAS really are specifically for the G12C alteration and don't have activity against other KRAS mutations, which unfortunately have been found to be mechanisms of resistance to some of these drugs. So that is absolutely correct. We do now have FDA-approved therapies for exon 20 insertions. That's the Amivantamab and mobocertinib that we talked about, as well as RET fusions. You can go to the next slide. So just to briefly highlight one other area of developing data for targetable alterations in lung cancer, which is HER2 activating mutations, which are a smaller subset of mutations that we see in non-small cell lung cancer, but do not currently have any approved targeted therapies. These are often also insertion mutations, like we had talked about for the exon 20 mutation, and were recently evaluated in the DESTINY-Lung study using an agent called trastuzumab deruxtecan, which is a HER2 antibody drug conjugate. You can go to the next slide. So in the DESTINY-Lung study, which looked at trastuzumab deruxtecan in previously treated HER2 mutant non-small cell lung cancer and was recently published in the New England Journal, you can see here that there was quite encouraging objective response of over 50% of patients having a response in this study and a disease control rate of 92%. Those responses were seen in a little over 1 month, and the median duration of response in this study was a little over 9 months. You can go to the next slide. And again, just like EGFR, all these HER2 mutations are not the same. So they looked at for the subclassifying based off the location of the HER2 mutation and found activity for trastuzumab deruxtecan, either in patients that had kinase domain as well as extracellular domain mutations, which are summarized in this waterfall plot here. So encouraging activity for another agent for HER2 mutations in non-small cell lung cancer, and likely something we'll see more of in the future. Go to the next slide. So I'm going to switch gears completely from targeted therapy for lung cancer to immune checkpoint blockade, which in advanced non-small cell lung cancer has really changed dramatically our treatment approach and prognosis for patients, and is now moving into earlier stages of disease. Next slide. So to briefly summarize, immunotherapy in lung cancer is based off of using antibodies that block receptors on T cells, which are one of the main immune cells that help to recognize and clear cancer, that allows those immune cells to become more activated. So we have antibodies that target CTLA4, which is involved in sort of the early steps of immune activation, as well as PD-1, which is another receptor that's present on T cells and can block their activity. We also have antibodies that block PD-L1, which is the ligand for PD-1, which causes T cell activity to become decreased. So these drugs are already approved in a number of different combinations in later stages of lung cancer, and we'll review some of the data for biomarkers to select patients for these therapies on the next slide. So because PD-L1 is one of the targets of these antibodies and is a marker of potential immune activation against cancer, it's been the most widely used biomarker for selecting patients for immune checkpoint blockade, particularly in lung cancer. So PD-L1 is assessed by immunohistochemistry on a tumor specimen. Can you click forward, please? As shown here, you can see PD-L1 expression both on tumor cells, so TCs, as well as immune cells in the microenvironment. And in lung cancer, the predominant biomarker that we use is something called a tumor proportion score, which estimates the percentage of the tumor cells that show positivity for this PD-L1 biomarker. Next slide. And so in advanced stage lung cancer, there are a number of different immune checkpoint antibodies that are approved. There are drugs that target PD-1, such as pembrolizumab, nivolumab, or cemiplimab. PD-L1, again, several drugs that target these agents, and then CTLA4 antibodies as well. And I'll go through some of the data on specifically the drugs that are now emerging in earlier stages of lung cancer. Next slide. So to talk through this with a case, our patient is a 60-year-old male who has a 40-pack year smoking history and has a screening chest CT done and is found to have a 4-centimeter lung mass. They are referred for appropriate staging, which involves assessing the lymph nodes in the middle of the chest to see if they have involvement. And it shows that they have involvement of a hilar lymph node, which is considered an N1 lymph node. So at the time of referral to a thoracic surgeon, they have what would be considered T2N1 disease or stage 2 disease. They're evaluated by a thoracic surgeon and they're considered to be a candidate for surgical resection of their cancer. So are there additional treatments that we would do for this patient to increase their long-term survival? And yes, there are. We'll go through that data in the next slide. So in stage 2 lung cancer, adjuvant therapy with a cisplatin-based doublet has been the standard of care for many decades now for patients with stage 2 to 3A disease and a subgroup of patients with stage 1B disease that have greater than 4-centimeter tumors. And this is based off of a number of studies that were evaluated in meta-analyses and demonstrated to show an improvement in overall survival. But up until recently, this standard of care of post-surgical or pre-surgical platinum doublet chemotherapy hadn't really changed. And chemotherapy, while it does improve survival, the improvement is somewhat incremental. And so we've been looking for newer approaches to help improve cure rates for patients with early stage disease. This hadn't really changed until recently, the approval for adjuvant osimertinib, specifically in patients that have EGFR mutated non-small cell lung cancer. But because of the encouraging data for immune checkpoint in later stages of disease, this is something that has been evaluated now for patients with resectable lung cancer. And 2 main studies I'll go through on the next slide. So, if you could go back to it. There we go. So the Empower-010 study looked at patients post-surgery, so completely resected stage 1B to 3A non-small cell lung cancer based off of the AJCC version 7 staging system. And then the stage 1B group specifically included those patients with greater than 4-centimeter tumors. Patients could have had a lobectomy or a pneumonectomy, and they needed to have tumor tissue for PD-L1 analysis. Patients then went on to get standard of care platinum doublet chemotherapy with cisplatin plus a second agent determined by the histology, squamous versus non-squamous, and then were randomized 1-to-1 to either receive atezolizumab, which is a PD-L1 antibody, or best supportive care. Important stratification factors in this analysis included patient stage and PD-L1 tumor status. And the primary endpoints of the study were disease-free survival that was tested hierarchically, first in the patient population that had PD-L1 positivity of greater than 1% in stage 2 to 3A, and then in all randomized patients. Secondary endpoints include overall survival. So we currently have data on the next slide, can talk through for disease-free survival from this study. And this is in the patient population with stage 2 to 3A resected non-small cell lung cancer with a PD-L1 tumor cell percentage of greater than 1%. As you can see from the Kaplan-Meier curve here, atezolizumab significantly improved disease-free survival in this patient population with a hazard ratio of 0.66 and a p-value of 0.004. Next slide. They did then go on to look at a number of different key subgroups in this study, and you can see that the improvement with atezolizumab was seen across various age, race, gender categories. But one of the particularly important subgroup analyses that we were interested to see was the improvements based off of PD-L1 status. So you can see here that the hazard ratio was particularly improved in patients that had a tumor cell staining of greater than 50% with a hazard ratio of 0.43, but was improved overall in the greater than 1% population. And importantly, there was not an improvement seen in the patient population with tumor cell less than 1%. Compared to best supportive care. Next slide. So based off of that data, atezolizumab has been approved for patients with stage 2 to 3A non-small cell lung cancer at a tumor cell percentage of greater than 1% as adjuvant therapy after surgical resection and platinum doublet chemotherapy. And we're eagerly waiting to see the overall survival results from that study. So next question, which biomarkers are used to select patients for checkpoint inhibitor therapy in non-small cell lung cancer? Okay, well, I guess that was an easy one, but that's right. PD-L1 immunohistochemistry is really the main biomarker that we use. There are a number of other markers that are exploratory, like gene expression profiling signatures, but not something that's clinically relevant quite yet. You can go to the next slide. So the second study that I wanted to review is the CheckMate 816 study, which looked at the role of nivolumab in patients pre-surgery. So this patient this population was similar to the previous study we discussed, included patients with stage 1B tumors that were greater than 4 centimeters to stage 3A, that is 7th edition staging, no known EGFR or ALK alterations, given that we know that immune therapy is not as effective in patients with these driver alterations. And they stratified patients based on stage as well as PD-L1 expression. And in contrast to adjuvant atezolizumab, this study randomized patients prior to surgery to either nivolumab, which is a PD-1 antibody, plus a chemotherapy platinum doublet that was based off of histology for 3 cycles compared to chemotherapy alone. And after 3 cycles, patients underwent radiologic restaging and then went to surgery with optional adjuvant chemo and RT per investigator discretion. The primary endpoint of this study was pathologic complete response, so the absence of tumor in the pathologic resection specimen at the time of surgery, and then other important endpoint, event-free survival. Secondary endpoints included major pathologic response, which is when there's less than 10% viable tumor in the resected specimen, and overall survival. So going through some of the data from the CheckMate study on the next slide, we saw that an approach of using neoadjuvant nivolumab plus chemotherapy significantly improved the pathologic complete response rate, which was 24% in patients getting the combination therapy relative to just 2% in patients with chemotherapy alone. And similarly, the major pathologic response rate, which is when there's less than 10% viable tumor, also significantly improved to 36.9% for the combination relative to chemotherapy. Next slide. This improvement in pathologic response was seen across stages that were included in the study, from stage 1B to stage 3A is broken down here. Next slide. And you can see from this slide that the depth of responses was quite striking. So looking kind of at the left figure here, which focuses on the patients that got PD-1 plus chemotherapy, in addition to the group of patients that had a pathologic complete response rate, they also looked at the percent of patients in which there's major pathologic responses, so less than 10% viable tumors. And the median residual viable tumor percentage went from 28% in the stage 1 to 2 patients with the combination therapy compared to 79% of the chemotherapy. So pretty striking improvements in pathologic response. Next slide. Since this was a study that was changing the treatment prior to surgery, one of the important outcomes was surgical outcomes on this study, which was presented last year at the American Society for Clinical Oncology meeting. And so this table summarizes the surgical delay rates across the different stages of patients for either nivolumab plus chemotherapy or chemotherapy alone. And what you can see looking at this table is that essentially there really was not any significant increase in the delay to surgery in patients that got neoadjuvant immune therapy. So the median time from the last dose of their neoadjuvant therapy to surgery was a little over 5 weeks, both with the combination of nivolumab and chemotherapy as well as chemotherapy alone. And on the next slide, we will summarize the data from CheckMate 816, which also now has event-free survival data that's been not presented, but we eagerly look for that showed that patients that got this combination approach had a 37% reduction in the risk of progression, recurrence, or death at the hazard ratio of 0.63. And this was across patients with stage 1B to stage 3A disease. So based off of this data and the encouraging pathologic response rates, this has now been approved by the FDA very recently as a combination approach that can be used in patients preoperatively. And we'll look forward to seeing more data on this to be presented this year at AACR, and then both overall survival data for this study as well as the Empower study in the future to see if with these combination approaches we're improving overall survival in early stage patients as well. So yeah, that was a question. Just a true or false, adjuvant immune checkpoint blockade improves disease-free survival in resected stage 2 to 3A non-small cell lung cancer with a PD-L1 score of greater than 1%. So yes, that's true. We had seen that just from the data we talked about here in the Empower 010 study. And then we also now have data for the use of neoadjuvant immune checkpoint blockade with nivolumab in combination with chemotherapy for patients pre-surgery. I think we will go to the summary slide now. So summarizing what we talked about today, if there's one big take-home point in management of these patients, genomic profiling is really important for non-squamous non-small cell lung cancer, and complete profiling for treatment selection, whether that is a combination of tissue-based testing alone, if it can comprehensively evaluate for all biomarkers, or tissue-based testing plus blood-based testing. The number of agents that we have that target specific genomic alterations is expanding in lung cancer, with new agents targeting KRAS G12C mutations, long considered undruggable in lung cancer, as well as EGFR exon 20 insertion mutations, all just highlighting the importance of comprehensive biomarker testing. And We're now seeing a role for immune checkpoint blockade in patients with earlier stages of disease, those that get resection for their stage 2 to stage 3 lung cancer, with atezolizumab approved post-resection and platinum chemotherapy for patients with a tumor cell percentage greater than 1%, and nivolumab in combination with platinum chemotherapy approved in the neoadjuvant setting for stage 1B to 3A patients, and that is irrespective of PD-L1 expression at this time. So I will stop there and take questions as they come.
Great. Dr. Patel, thank you so much. Let me just put up your acknowledgement page there.
Yes, and this is our thoracic oncology group.
Great. Thank you so much. And as mentioned, we have our questions section of the Poll Everywhere open now. So please go ahead and share those via Poll Everywhere with Dr. Patel, and we'll get to as many of those as we can. While we're waiting for those to come in, let me ask, should we hopefully have you back in a few years? What's on the horizon? What do you think we might be talking about in a couple of years that we were not able to talk about today?
Yeah, I think that the themes of more agents for targeted therapy will continue. I think with newer generation drugs are being evaluated for not just KRAS G12C inhibition, but some of the targets that we recently got approvals for, such as RET, that have improved activity. So I think we'll continue to see more targeted therapy approvals in lung cancer. And then for KRAS, while the current data is quite encouraging, and it's nice to have that as a treatment option, I think combination therapies are really going to be something that is being evaluated currently and may be more part of our treatment paradigm going forward.
Great. Thank you so much. And I see we already have a question in. What is your take on molecular testing and genomic profiling for squamous NSCLC?
Yeah, it's a great question. So unfortunately, in squamous cancers, we haven't found frequently targetable alterations, except there's a subgroup of patients which I'll commonly consider it for, and that's patients where you find squamous cancer that have a limited smoking history. And because sometimes with our sampling, we may be only looking at a part of a tumor specimen, you may have something that doesn't have clearly an adeno or squamous histology. And so those patients I will still consider testing for. And then patients that are more advanced and have exhausted standard of care options, the testing in those squamous patients can sometimes be helpful for identifying clinical trials, but not necessarily standard of care therapies, because there are some alterations in squamous lung cancer that are being explored in clinical trials. So that's what I would typically test it in, but I don't routinely test do genomic profiling in squamous patients just because it's a low percentage of patients who have targetable alterations.
Great. Thank you so much. And another question, how are you deciding who will get neoadjuvant versus adjuvant versus surgery alone in early stage NSCLC?
Yeah, again, a great question, given that we have two studies that evaluated the role of immune therapy separately in the neoadjuvant and the adjuvant setting. I think at this point, we don't have an objective criteria to decide on whether neoadjuvant or adjuvant is better. I think we'll see some of those studies in the future, certainly. There is a biologic rationale that neoadjuvant immune therapy in particular may be better, and while you have the tumor there and the antigens that are getting reactivated, you may have improved response systemically from that. That's been seen in preclinical models, but we'll really have to do the studies to see if that's the case in patients as well. I think if the place where neoadjuvant can be particularly helpful is, people that you might want a response to or want a little more time to get them to surgery, for example, if they need some, additional conditioning testing, things like that. Those would be ones where neoadjuvant therapy may be helpful to be able to get a response before they can get to their curative surgery. I would offer some kind of adjuvant therapy to all patients with stage 2 to 3 resected disease. The stage 1B is a bit of an open question just because it's based off of relatively small studies, the greater than 4 centimeter population. But stage 2 to 3, I would discuss with all patients, certainly.
Thank you so much. And thanks to our audience. These questions just keep coming in. These are great. Do you think all PD-1 and PD-L1 agents are equivalent? Or are there differences in clinical outcomes?
That, again, is a great question. We don't have any comparison data, so kind of cross-study comparison, which always has its caveats. The PD-1 and PD-L1 agents do seem to have similar activity. Aside from avelumab, which in lung cancer did not seem to have as good of activity when it was looked at in the post-platinum setting.
All right, thank you. And what is the role of gefitinib in treatment?
So gefitinib, for everybody else, is a first-generation EGFR inhibitor. So one of the drugs that we were using more commonly before some of our later-generation EGFR drugs like osimertinib became available. So at this time, it's not something I commonly go to as a first-line agent for EGFR mutant patients.
Great. And we'll take this final question. Does your pathology department routinely submit specimens for testing, or do you have to order the specific testing to facilitate getting results readily?
Yeah, so this seems to be institution dependent, and our practice has been that pathology will typically do PD-L1 testing on all lung cancer specimens because that is important both in squamous and non-squamous lung cancers, and then usually defer to the clinician to order genomic profiling for the non-squamous patients just because they may not know if it's indicated for every patient. But that is institution dependent. Certainly at other places there is reflex genomic profiling, and we could, I think, have a good discussion about whether the reflex versus the clinician triggered is the way to go. I think this is such important testing for treatment selection. My bias is to have it be reflex testing just so it's done and available for patients early. And so that treatment decisions can be expedited. But I think that the important thing is that patients get it at the end of the day.
Great. Thank you. And we are now at the thank you portion of our presentation. So we want to thank you, Dr. Patel. This has been phenomenal. We really appreciate it. We want to thank our audience. And of course, without our audience here, this all wouldn't work. So we want to thank each and every one of you who is joining today. I already see comments popping up. Wonderful presentation. And I'm sure there'll be some others in the chat there as well. We want to thank the state of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, John Powell, Jason Paler, Veneranda Obore, Oliver Marth, and Andrew Dodgson for all of their hard work on each and every one of these presentations.